Good afternoon, everyone, and thank you for joining us in this second of our series of webinars from Ophthalmic Consultants of London. Due to high demand, we've managed to add today's webinar into our programme. Tomorrow's webinar will still be running, details of which I will give at the end of this programme. There is one CET point available for this webinar for optometrists, dispensing opticians and therapeutic optometrists. This lecture will run for around 45 minutes with questions at the end. So at the bottom of the screen, you will see a Q&A box. So if throughout the lecture you have some questions, please type them into that Q&A box and we will go through them at the end of the lecture. So today's speaker is Mr. Shah Kashani, a consultant ophthalmic surgeon who works with us at OCL. He has specialist expertise in management of complex and challenging medical retinal disorders and performs a high volume cataract surgery, intravitreal anti-VEGF injections, intravitreal steroid implants, as well as anterior and posterior segment laser treatment. So let me introduce you to him. Shah, over to you. Thank you.
Well, thank you very much, Purvi. I just wanted to also thank Veronica from OCL and OCL for allowing me to do this talk. Before we start, I should probably just tell you this is my first webinar, so please excuse me if I'm going too fast or too slow. But I've essentially prepared some slides for you, which hopefully you should all be seeing. And the aim of this talk really is about what kind of retina patients you should be worried about. And, you know, it could turn into, we could have other discussions at the end. And if you have any questions, please don't hesitate to ask them. So just a few contact details, my email, obviously, if there are any specific questions at the end. My website, as you might see, I work in Eastbourne, but I consult at OCL on Fridays. This is my Twitter account and Instagram on the picture. I do sometimes post interesting pictures and discussions on Instagram, but obviously with COVID and everything, we don't have a huge number of patients coming in, but hopefully that should all get going once we go back. So really, what I wanted to talk to you about were the aims of today's talk is about common symptoms that you should be concerned about with patients with retinal disorders, what you might find examining patients with retinal disorders, and who you need to refer. And I've particularly prepared this talk with COVID in mind. So this is particularly relevant for our time, and really timescales for referrals, because I get a lot of emails or requests with different retinal issues, and I think we can probably manage those better, certainly where we work. So just going on history of alarming symptoms, as you can imagine with retinal disorders, many patients present with central loss of vision. And in particular, we tend to panic as retinal specialists with respect to macular disorders, because often, as you all know, the fovea is such a small place, and it only takes a very small insult to cause permanent damage to that. So central loss of vision is quite important, in particular if it's sudden. Distortion and gaps in central vision, very common, and you've all had Amsler charts to test patients. That's one of the things that we use in order to gauge whether somebody's distortion is worse. And this is very varied. It's not a brilliant marker of knowing exactly when somebody's AMD might become active or somebody's suddenly developing symptoms. But so that's what we have at the moment, and it's easily downloadable and used. Loss of color vision and fine detail is also quite important. Because your macula involves color vision and fine detail. Color vision is also very important for optic neuropathies, but you'll probably hear more on that in these webinars. You won't be getting it from me. Peripheral shadows, flashing and floaters might suggest something else that's going on with respect to peripheral retina. In particular, I'm thinking about retinal detachment, posterior vitreous detachment, and so forth. In general, macular disorders should give you a positive scotoma. So unlike patients with glaucoma and so forth, positive scotoma is quite an important feature, and patients often present saying, I can't see something central of my vision. Now, kind of incorporated a bit of uveitis into all this, and that's because uveitis is part of the retina spectrum, but it doesn't, I won't be covering much of that, and perhaps we can have another teaching session around this, but I will kind of mention what to look out for. So in particular, a lot of retinal conditions that I'll be discussing with you today will be painless without any redness of the eye, unlike anterior segment disorders. But when you do have pain and redness with respect to retinal problems, you should think about inflammatory eye disease. Gradual loss of vision, night vision issues are more kind of indicative or more slow growing problems in the back of the eye. And of course, if there's a family history, you should think about inherited disorders. So in general, any sudden loss of central vision should be alarming to you, in particular positive scotoma, or anyone coming in with sudden onset of flashing, floaters, or shadow. Pain and redness with uveitis. So here's a picture of retina. I always find it very important to go back to the anatomy. I think when you can think about the anatomy and when you know what's happening within the anatomy, then you can see where the problems are coming from. So just here, you can hopefully see my cursor. You can see the retinal pigment epithelium, underneath which is the choroid. You've got the photoreceptor layer. This is kind of the middle part of the retina, and this is the inner retina, and you've got vitreous on top there. And in essence, you've got 4 cell lines that you can see. So 1, 2, 3, 4. But when you look at OCT, the picture is completely different, and we look at different layers and different things. So here I've got a picture of an OCT, and you can see there are a lot more layers. So within those 4 cell lines, you've got your photoreceptor layer and your outer and inner nuclear layers, etc. So it's important, again, to understand the anatomy, because when you look at problems with the OCT, and I would imagine a lot of you have OCTs at your practice, it will be very important to know where the problems came from, so you can kind of try and establish a diagnosis. Now, that is a whole different talk on its own. I have got an OCT talk that I hope, if you guys are interested, we'll be doing at some point. Just looking at various conditions and how from OCT you can diagnose things. But I will touch base on that a little bit today. So let's start off with the first case. 73-year-old man who complains of positive scotoma. He can't see far or near, fairly sudden onset, and everything seems very distorted. So immediately with that history, you should start to think that there could be a problem with the macula. Now, hopefully this projects well. When you look here, the most obvious abnormality is a lesion, which is very central and in the macular area, and it's red. So you're thinking that there is a macular hemorrhage here. If you are looking at this picture, you need to just see that the blood vessels look okay. So you're kind of thinking, well, if this was a retinal vein occlusion, I'd see tortuous vessels. I see a lot more hemorrhages around the retina. There's no other signs of exudation or microaneurysms suggesting diabetic retinopathy. So really, in a patient of that age, you're thinking wet macular degeneration. And you can see a bit of pigments here, which might help with that diagnosis. And here's kind of what the patient generally sees with respect to a big central scotoma. Peripheral vision is spared. And this is what we used to do in the past. We used to angiogram patients. So they get fluorescein angiography injected, and you could see the membrane light up in the center. So that would clinch the diagnosis of choroidal neovascular membrane. Nowadays, to be honest, most of us in hospitals just use OCT, and I'll show you some pictures of that later if there's time today. And OCT angiography, actually, which is dye-less, and you could do this without putting the patients through this procedure. But if I've got a patient who is also diabetic, or where the OCT might not be 100% clear, it is worth doing fluorescein angiography, because there are conditions which mimic with macular degeneration, and prognosis is different, treatment protocols are different, and in that case, it might be worth putting them through a fluorescein angiography. But I think I use it 10 to 20% now in patients, and before I used to do fluorescein on everyone. So with wet macular degeneration then, positive scotoma, sudden onset, loss of vision, often out of proportion to what you can see in the back of the eye. You look at the macula, you might see a little bit of hemorrhage, but they definitely are very symptomatic, and the vision is significantly affected. And the reason for that is because with wet macular degeneration, the disease is coming from the choroid. So it's disrupting the RPE, it's disrupting the photoreceptors, and therefore causing a lot more damage. It's always urgent, and you must all be aware of your local protocols and referral pathways to your local units. And the usual target for this referral to treatment time is around 2 weeks. So if you've got a patient with wet macular degeneration, I would refer that patient that day, because that will allow us time to see the patient, organize another OCT perhaps, and start treatment. So from the day we get the referral from you, we need to start this patient on anti-VEGF therapy within 2 weeks. I've been a consultant now for around 10 years. And I would say I've seen patients who have been referred from the optician with vision 6/9, 6/12, and within a week, they've gone down to counting fingers. So it can be very aggressive. And you can have wet macular degeneration, which starts off with 6/9 vision. 3-4 months down the line, vision might just slightly go down. And as you're all aware, with NICE criteria, they used to say they still say 6/12 vision to treat on the NHS. So sometimes if the vision is 6/9 and they're not seeking private treatment, they have to wait till the vision drops. And I have seen low-grade wet AMD where it takes a bit longer. So presentation can be different, but as far as you're concerned, treat that day. And I've written classic membranes. We used to talk about classic and occult quite a lot, and it's to do with where the abnormal blood vessels are situated. So often, when the blood vessels sprout through the retina and are sitting within the retina, the damage is more aggressive and more quick, but these patients tend to be more responsive to treatment. With the occult, it's opposite that. So if you've got a patient with a classic membrane, often the vision will go down quite quickly. These angiographic definitions are important, because when you think about all the new treatments like radiotherapy that some people talk about, or the X-ray therapy, as Daily Mirror would call it, you do have to define the membrane, and it is not applicable to every patient with wet AMD. Okay, so the take-home message with the first case was then refer on the day if you suspect wet AMD. Now, case 2, type 1 diabetic. They've been diabetic for about 10 years, and the diabetes is poorly controlled. They have missed the last screening appointments, and now they're getting flies in the vision. Well, if I ever speak to a diabetic who says that they have had floaters in their eyes, I would always panic. Because one thing you can never not worry about, or you should always worry about, is proliferative diabetic retinopathy, and that is urgent. Like wet AMD, when you see a patient with proliferative diabetic retinopathy, they need laser treatment ASAP. And the current protocol, even if we get them from diabetic screening service, is that we need to see and treat again within 2 weeks. So as you know, with COVID, at the moment, there's a lot of questions, and people panic if they speak to somebody with diabetes. One thing you might want to know is if they've been going to the screening service and what the last screening test showed. So in fact, I had a patient the other day who called me up because he had floaters, and he'd been to screening service a few months ago, and he was given the all clear. So it would be very unlikely for that patient to have suddenly developed rampant peripheral diabetic retinopathy. But in a diabetic, especially if you can't establish when they were last seen or how things are going, floaters is important. That's what you want to not see. So this is a patient, unlike the wet AMD, you could see that before the hemorrhage was very much macular. This hemorrhage is very extensive around the disc and inferior, and is sitting just between the retina and the vitreous. So he hasn't quite gone in the vitreous yet. And this patient needs urgent laser treatment or they're going to lose all the sight. One of the problems with diabetic retinopathy is that it can become advanced and the blood vessels can go in front of the iris and block up your trabecular meshwork, causing neovascular glaucoma. So you want to avoid that at all cost. And I don't apologize for this poor quality picture because you can't get a better picture than this. Vitreous hemorrhage is vitreous hemorrhage and you can't see the back of the eye. So you might just about see the glimpse of the optic nerve. At this point, it is too late to treat this patient because you can't actually see the retina and apply laser. So what you would need to do is, or what we would do is do an ultrasound to make sure that the retina is attached and allow this to settle. I think most VR units now want, sorry, vitreoretinal units, now want these patients sent earlier than later. And by the time they've given an appointment, if the hemorrhage hasn't resolved, then they would have to remove the jelly and apply laser once the vitrectomy is done. And again, this is kind of a simulation of floaters. I'm not talking about one floater here and there. I'm talking hundreds of floaters because you're seeing the red blood cells in the vitreous where they didn't see before. So this is an acute presentation of floaters, quite different to a vitreous detachment where they might see a Weiss ring or a cup shape moving around. This is different, you know, lots of little floaters moving around. And as I mentioned, it does require a urgent referral. If I saw one and if I could laser there and then, I would laser there and then. I certainly wouldn't want to bring them back. So from your point of view, if you're concerned, send them straight up. R3 is the kind of what nomenclature we use for diabetic screening service. So R3 means query proliferative disease, and the time to see that is normally within 2 weeks. So it's important for us to see these patients quite quickly. And what we normally do is actually laser the inferior retina. And if I had you all sitting in front of me, I would ask why. But as we are on a webinar, I can't do that. So the reason for that is because the hemorrhage eventually settles down. So you want to cover the inferior retina first. As later on, when the hemorrhage resolves, it all settles down and then you can do superior retina. But to be honest, if I get my hands on one of these cases, I'll do as much laser as possible because you need to treat. And the way laser works, it kills off the photoreceptors in the periphery, which are releasing all these horrible vascular endothelial growth factors, making the blood vessels grow. So you need to kill the stimulus off. Everything, obviously, if there's no view, then at some point you might need vitrectomy, but an ultrasound will be useful to make sure that there is no other cause. So just because they're diabetic, don't always assume that it's proliferative diabetic retinopathy, especially if the diabetes had been well controlled, and especially if they've had recent screening service appointments and they've been given all clear or very minimal disease. So this is what we want to avoid. Really, neovascular glaucoma, by this point, it's too late. You've got blood vessels everywhere. You can't see the back of the eye to treat. And you can see here just fibrotic tractional detachment developing. In fact, neovascular glaucoma is the second commonest cause of evisceration following kind of tumors for which they do enucleations for. So it can be very painful, and we really, really, really don't want patients to get to this point. If caught early, then you can see lots of lovely laser marks in the periphery, and we laser the retina as much as needed to stop this stimulus. Some patients might need 2 or 3 rounds of laser. Some patients might need a lot more. And there's growing evidence actually that you can use anti-VEGF therapy, although that's not at the moment approved by NICE, but there is evidence from America and studies to show that actually in conjunction with laser therapy, anti-VEGF therapy such as Lucentis or Avastin or Eylea can help with this proliferative retinal disorders. And I think over there, what they're doing is they're doing kind of a mix and match, because one of the issues with peripheral laser, as you know, is driving, and we are often dealing with quite a young population of patients who need driving. So that's an important thing to discuss with them. Diabetic macular edema. You're going to remember one thing from this slide, it's not urgent. So unlike wet AMD, unlike peripheral diabetic retinopathy, we can wait on diabetic macular edema. And the reason for that is because the problem with diabetes is to do with retinal vasculature. It's not coming from the choroid. So when the blood vessels leak, the leakage doesn't damage the photoreceptors compared to wet macular degeneration, when you get sprouting of blood vessels damaging RPE and photoreceptors. So often with diabetic macular edema, we can watch, certainly during the current COVID crisis, hardly any patients with DMO are getting injections unless their DMO is really bad and the vision's going down. So you can't sit these ones out. And as you might imagine, you'll get central scotoma or distortion. Amazingly, I've seen patients with really, huge macular edemas, and yet they don't complain of that much distortion or vision reduction. So again, it is a bit variable, but obviously nowhere near the damage you can get with wet macular degeneration. Okay, so the take-home point from that was, do worry about an acute onset of significant floaters in a patient who is diabetic, especially if you're worried that they have other comorbidities or the retinopathy has not been seen for some time. Case 3, so sudden onset of floaters for a few days, and vision is quite good, no RAPD and good red reflex. So this is a completely different clinical scenario. As you can see, the hemorrhage is not in the center, so it's kind of further up. And as I've pointed here, if you follow the retinal artery here, as it's going through, it's difficult. You see a pale area on the retinal artery. And this patient has got kind of hemorrhage in all layers of the retina. And the reason you know that is because the next picture will show you. If you've got an intraretinal hemorrhage, so the white is the artery, okay? Intraretinal hemorrhage will block the artery because these blood vessels are kind of going into the middle of the retina. So the hemorrhage is obscuring your view. Subretinal hemorrhage is underneath the retina. So you can see the blood vessels over it. And then you can just see vitreous hemorrhage. You might have been nice in that one. You can just see here, vitreous hemorrhage. So this is one of the few conditions where you can actually see hemorrhages in all the 3 layers: sub, intra, and vitreous hemorrhage, and it's a macroaneurysm. So a macroaneurysm is an aneurysm is dilation of a blood vessel. A microaneurysm, what you get in diabetes, is dilation of a capillary, which is a very small, obviously, blood vessel. But in a macroaneurysm, it happens within the first 3 divisions of an artery. So it's quite a big dilation, and you can get hemorrhaging and you can get exudation. Now, it looks horrendous because when you look at it, you think, gosh, this patient needs to be seen urgently. But actually, most of the time with a macroaneurysm, we wait and see whether the hemorrhage will dissolve. You only need to do something about a macroaneurysm if you've got lots of macular edema and exudation coming down towards the macula. And even then, what you do is you laser the macro itself. So it's not something that we would need to see as acutely as proliferative retinopathy from diabetes or wet AMD, but you do need to refer it, and we will see it in due course. And essentially, the treatment involves lasering the macroaneurysm itself so it stops leaking. I usually give them time to see in a few weeks, whether the hemorrhage is increasing or the macular edema is increasing or whether the macula is being threatened. But if it's not, or if it's going away on its own, we don't do anything. The problem with laser is that sometimes you can burst the aneurysm, so then they can get a massive vitreous hemorrhage, which would then need vitrectomy and etc. Or sometimes you can block the artery away from the aneurysm, so you can get an arterial occlusion. So you do have to judge that. One thing you could do is make sure that the patient has got a blood pressure, because hypertension is associated with macroaneurysms. And when you get multiple macroaneurysms in the retina, then a carotid Doppler ultrasound is something that we do. Another condition which causes multiple hemorrhaging is not this one. In the 3 layers I mentioned is macular degeneration, wet macular degeneration. This was an unfortunate gentleman who came to us, and he was quite young, constipated, and essentially came with sudden loss of vision. And some of you may have guessed what this is. So this is Valsalva retinopathy. Valsalva retinopathy occurs because you have hemorrhage from the retinal vessels that are on the surface of the retina. So these are kind of what you can see, fluid levels, if you will, yeah, like that. And the blood is between retina and the vitreous. So he's young, so the vitreous isn't detached. So when they've had bleeding, the blood occurred between retina and vitreous, and the vision at this point is counting fingers. So what we do in this circumstance is we use YAG laser, and we can laser the hyaloid around about where I'm showing, away from the center of the macula. Don't try this at home. And then the hemorrhage will bleed into the jelly of the eye, jelly of the eye. So you're inducing a vitreous hemorrhage, but then the hemorrhage level comes down and the macula, they'll be able to see from the macula. So again, often with this condition, if you think that the patient's significantly affected, we do want to see them sooner than later, because the sooner you do the laser, the better. And also, if you leave the hemorrhage there for long enough, the macula can become damaged from iron toxicity. So it's not something that we would leave behind. Right, case 4. So this patient has history of flashing lights and floaters. Left eye seems fine. He's noticed a shadow, especially, the shadow appears to be coming from the bottom, and it doesn't move. No other previous problems. They have a superior visual field defect. So it's a very nice picture that we have from somebody who has a retinal detachment. So often preceding retinal detachment, there's usually traction of the vitreous on the retina. You have a tear, and the retinal tear can become a detachment. If you have got a superior retinal detachment, then you start off with an inferior visual defect, and vice versa. So remember that. This is an urgent referral because macular on retinal detachment. So one of the poor prognostic factors with this condition is if the macula comes off and it stays off for a long time. So as long as the macula is on, or even if the macula has come off, but it's within a week or so, then it's quite useful to see these patients straight away, so we can refer them on to a tertiary center. And essentially what they do is they do a vitrectomy and stick the retina back using gas, or if they need to, something stronger like oil. But normally they try gas first, and to try and prevent the vision going down. So really, if you've got somebody with flashing lights, floaters, shadow in particular, but they've got good central vision, you do need to see them to ensure that they are seen. I do get asked, oh, everybody calls up with floaters, and how often do we need to see them, and flashing lights, and especially with COVID going on, what do you do? My kind of rule is, obviously, you've got to think that we are in extraordinary circumstances. You can't see everybody. You have to balance the risk of somebody becoming infected versus doing something for them. So floaters is a lot more important than flashing lights. So that's a much more important symptom. So if you've got an acute floater, Not somebody who says, I've had floaters for 3 months, I think it might be a bit worse. You know, yesterday they were fine, today they're walking up with this thing in front of their eye moving around. That to me is an acute floater, and it does need examining. Because they might have a tear, and that tear can then become a retinal detachment. Certainly if they tell you, look, floater started a few days ago, it's getting worse, now I have a shadow, that, you know, you must see that, because that sounds like a retinal detachment. I mean, you ask about central vision. If the central vision is not impaired, then even more important. Chronic MAC-off retinal detachment, so, you know, the retina's been detached and the vision's been poor for a long time, does need fixing because it can become ischemic and cause neovascular issues, such as neovascular glaucoma. So the retina does need to be put back, but it's not as urgent as an acute MAC-on detachment, or if the macula has just come off. So acute floater, so you need, and sometimes I kind of think, well, if you had it for 2 days, then you need to see within 48 hours. If it's just started today, try and see them on the day. So if it is acute, and they've definitely got, they didn't have it before, it's sudden onset, they can see it move around, you should see a floater, especially if they've got a shadow. I'm sure there'll be lots of questions about this afterwards, but I'll answer them when we've finished. This is a nightmare scenario for any surgeon, really, when your patient comes up after an injection treatment, and we have given them an injection and they come with pain and redness. And I'm sure some of you might have heard patients kind of calling you up saying, oh, I've had an injection and what you want to do about it. Well, this is kind of the one scenario that we all worry about, endophthalmitis. So my usual rule of thumb is that when you do an injection, certainly within the first 24 hours, I tend not to panic about pain, watery eye, and blurry vision. And that's because infection is very unusual in the first 24 hours. But after that, so day 2, day 3, day 4, it becomes a lot more frequent. And then having said that, after 2 weeks, it becomes quite unusual to have an infection as well. So really, from day 2 to day 14, that's when your patients are at risk. So you do an injection, and, in the morning, the patient calls up and says, yeah, I had a terrible night, but actually I'm much better. You kind of realize that actually it was probably a corneal abrasion, or they do have a lot of toxic reaction to povidone iodine, which is absolutely essential for doing injections and minimizing risk of infection. There's a recent study that looked at patients who had povidone iodine and those who didn't, and the risk was 20 times higher endophthalmitis in those who hadn't. And there are a lot of people who say they're allergic to povidone iodine, but in fact, all it is that they're intolerant. So you have to be very careful if you're not going to give somebody iodine before an injection. But having said that, I think it's important to, in these patients, to get a clear history. So if it's more than 24 hours, they're saying they have pain and the vision is blurred, they must be referred, they must be seen, because every second counts with endophthalmitis. So if you've got a patient, during the day that you think endophthalmitis, it needs to go to theatre straight away. The sooner you can do a biopsy and inject those intravitreal antibiotics in, the better. So the sun doesn't go down on one of these. And this is obviously really bad. You've got hypopyon, cornea is very edematous, the eye is looking horrendously red. So in the history, CT examination, any sort of surgery really, cataract surgery or intravitreal injections, etc., if they're calling you with the symptoms of increasing pain, increasing redness, light sensitivity, decreasing vision, then we need to get a referral there, and then they need to be seen urgently in eye casualty. Luckily, the risk is around 1 in 1,000. As I said, if they haven't had iodine, the risk shoots up. And we mainly see this with intravitreal injections. It's quite rare with cataract surgery, can happen. Maybe that's to do with the fact that we use intracameral at the end of cataract surgery, and that reduces, or we just do a lot more intravitreal injections. So it's a numbers game, but 1 in 1,000 is a normal risk. Okay, so case 6, 70-year-old female, type 2 diabetic and hypertensive, sudden loss of vision, constant and painless. And they have got a relative apparent pupillary defect. So actually, when you're doing your examinations, I'm sure you do anyway, clear history, when you're examining pupil responses are very important, because RAPD in context of retinal disorders means something really bad has happened, especially if your optic nerve is normal. So hopefully most of you would know what this is. This is a very ischemic central retinal vein occlusion. So it looks different to wet AMD because obviously it's not purely macular. It looks very different to diabetic retinopathy because you have florid hemorrhages everywhere. You've got cotton wool spots. There is hardly any exudates, which would be unusual if somebody was diabetic. Of course, there are diabetics. I'm not saying there's no diabetic retinopathy at all, but the acute event here is central retinal vein occlusion. And why does it matter if it's ischemic or non-ischemic? Well, there are several reasons for that. First of all, prognosis is important. Ischemic central retinal vein occlusions tend to do very poorly. Secondly, non-ischemic central retinal vein occlusions obviously have a better prognosis, but a third of those who start off with non-ischemic become ischemic, irrespective of what you do. So I've had this with few patients who would come with non-ischemic central retinal vein occlusion, vision of 624 or 618. You give them injection to get rid of the macular edema, because that's all injections do. They don't reverse the blocked vein, but they can resolve your macular edema. The vision gets better. And then after the third injection, suddenly there's a drop in vision and they think it's the injection. But in fact, they are in that unfortunate group that has become ischemic. And when the fovea becomes ischemic, then the vision drops and there's nothing you can do. So the way you know if somebody is ischemic is you look at the vision. Normally vision of 660 or worse is suggestive of ischemia. Second thing is pupillary defect. So relative apparent pupillary defect would be another indication for ischemia. Third, presence of deep intraretinal hemorrhages. So I hope you can appreciate that there is a lot of very deep hemorrhages within this retina, and that's why the vision makes it ischemic. And finally, fourth was a fluorescein angiography, but we don't do that now because, you know, it would mean bringing the patient in and you know this is ischemic anyway, so it adds little. But in research studies, if you had significant non-perfusion on fluorescein, that would be another criteria. So the main thing with this is really, we do need to see the patient. Unlike wet AMD, we don't need to treat straight away. Obviously, the sooner you treat, the better. But as I said, I did have COVID in mind with this. So really, I'd like to see and treat this kind of patient within a month. Wet AMD, if you remember, I said was 2 weeks. But you know, there's no reason to wait for a month. It's just kind of trying to prioritize services. So one thing that you need to make sure with a ischemic or a non-ischemic central retinal vein occlusion, as long as they've got macular edema, you can offer them anti-VEGF therapy. Prognosis is much worse if they are ischemic. If you think the ischemia is progressing or there's hint of any abnormal blood vessels, then pan-retinal photocoagulation. Branch retinal vein occlusion carries a much better prognosis. There's a lot of confusion about what kind of blood tests, and people used to organize all sorts, but actually all we need to do now is blood pressure, blood sugar, full blood count to check for kind of abnormal, if you've got polycythemia or something like that, when you've got loads of red blood cells running around, or ESR for inflammatory conditions. We just do these four now. Unless unusual features in somebody who's young, less than 50, or if they've got bilateral vein occlusion, then you need to start look at other things like coagulopathies and other issues that you normally might not expect. This is a picture of somebody with branch retinal vein occlusion. So you can see it's not the whole of retina, and you can see loads of exudates here with macular edema. Okay, case 7. So this patient has ischemic heart disease, atrial fibrillation, lupus, young patient, sudden loss of vision, painless and complete. And again, another relative apparent pupillary defect. So very similar to retinal vein occlusion, this is the opposite. So this is an arterial occlusion. You can see a very attenuated retinal vasculature and the famous cherry red spot. Please be aware that the cherry red spot doesn't stay there forever. It's an acute event. And you can see it because when you've got an arterial occlusion, you have massive ischemia and edema of the retinal tissues, which occurs everywhere apart from the center. The center, because of the foveal dip, doesn't become oedematous. And so you can see the red reflex from the choroid underneath, hence the name cherry red spot, okay? But unfortunately, there is no way back from this once you have an arterial occlusion. It's unfortunately the curtains. But what's very important is that you absolutely look at all the risk factors, because this is like having a stroke. So you need to check patient. We get an urgent referral to rapid access TI-18, who then organize bloods, ECG, echo, carotid Dopplers, brain imaging. Very important to exclude GCA, because the main thing is you need to make sure that the other eye doesn't happen to them, or they don't get a stroke. Cardiac emboli, so are they throwing off, blood clots from the heart, or fast atrial fibrillation, which is done through an ECG. But GCA is very important. So if you've got somebody with an arterial occlusion, you should ask them if they've got headaches, jaw claudication, scalp tenderness, things like that. GCA can be fatal, and it's important not to miss. So this is a patient with branch retinal artery occlusion. So you can see the plaque here, and you can see this white patch, which will disappear in time, because all this is just edema, which will get better in time. But this patient will have a superior nasal visual field defect. And with the central retinal occlusion, they won't see anything. Often they are either PL or NPL vision. Uveitis, I'm not really going to say a lot about uveitis, because that in itself is a lecture on its own, and to give it 2-3 minutes is injustice. But just to let you know very quickly, with uveitis, you must look at the back of the eye, okay? It's very important. You obviously do your vision, you do your pressure, but you must look at the back of the eye, because the inflammation could be at the back. And when inflammation is at the back, that means several things. Risk of systemic disorders suddenly becomes a lot higher, and risk of vision loss, blindness, becomes a lot higher. So your patients will come with the usual pain, photophobia, redness, vision loss. But actually, if the uveitis is purely affecting the back of the eye, you might not have pain, photophobia, redness. You might just have vision loss and floaters, which hopefully would trigger you to see the patient anyway. And they can or cannot be associated with systemic symptoms. Sometimes you have got time with uveitis. So I would always refer a uveitis urgently, because they need steroid eye drops in order to control the inflammation. One thing that a lot of people kind of forget to do is see patients with shingles and or anterior uveitis, and they don't look at the back of the eye. And sometimes they miss a viral retinitis in the back of the eye. So it's important at least once to look at the back and see what's happening. But the loss of vision, especially if the posterior segment is involved, is from macular edema, retinitis, vitritis, involving of the disc, or uncontrolled raised pressure. The way I look at uveitis is generally, do I have time to investigate? Because it could be infective, it could be inflammatory. If you're going to start immunosuppression, if it's an infective cause, you could potentially make them worse. But sometimes you don't have time, so you have to rely on history. So if the vision's down, there's disc involvement, massive macular edema, bilateral, both eyes, you might have to start immunosuppression before your investigations are back. You can start antibiotic or antiviral cover for that. If you're interested in a uveitis talk, please let Purvi know, and we can always organize that. But we could go on forever with this. So the main thing from you guys is that if you have got somebody suspected of uveitis, we do need to see them. Always look at the back, because posterior segment involvement is often a sinister feature, which could mean systemic involvement and could mean other things. One thing in particular, macular edema in posterior uveitis is a lot commoner with inflammatory conditions than infective conditions. So these are the two conditions that you cannot miss, or we cannot miss. This is primary toxo, so involving the disc, this patient needs treatment urgently, and this patient has a viral retinitis. I mean, this is a blind eye. They won't be able to see out of that, but you need to control it before you get retinal detachment, and look at the other eye more importantly, because often these patients have bilateral disease. I think I'm just going to very quickly show you this picture. So large pigmented lesion, macular, another urgent case you should miss, melanoma. So the things you need to think about is the TFSOM mnemonic. So look at thickness, if it's more than 2 millimeter, presence of fluid, subretinal fluid. This is where OCT can be quite useful. If you can show presence of subretinal fluid on OCT, then that's a sinister feature. If they have symptoms like flashing or a shadow coming in the vision, that's important. Orange pigmentation, which we call lipofuscin, is important. And of course, looking at margin and how close it is to the optic disc. You need a 2-week referral as you'll be suspecting ocular melanoma. So that's another one of your urgents. The not so urgents, you'd be surprised to hear macular hole. We're not saying macular hole shouldn't be treated. All I'm saying is that it's probably not in any of the urgent categories that I've discussed. You normally have a few weeks, perhaps 2 or 3 months to treat this. So the preceding that would be something like this, which is like a vitreomacular traction. Patients would have central distortion, etc. And when the vitreous comes off, you can form a hole in the macula, and you can get central loss of vision. But as I said, we would refer this on to vitreoretinal team, but they certainly, with the current crisis, I think they'll be waiting a few months before they fix that. And this is another one. So you can hopefully see a very distorted looking macula, and this is a patient with epiretinal membrane. Right, this was going to be my prize giving picture. This patient had road traffic accident and they had developed blurring of vision. And it was significant trauma involved, and this is what we saw on examination. So when Provi does open up the line and starts kind of, starts questions and answers, if you want to write what you think this might be, then let me know. Now, I think I might have a few minutes, she hasn't stopped me just yet, to show you some scans, if I may. I'll be very quick, because I know we are already, so that's the end of that talk. Okay. Now, as I said, don't worry, I'm not going to show you all these scans. There's not enough time anyway, but I've got a whole talk on OCTs, which I think would be really useful to have at some point. I've collected these images over, a good 10 years. So just want to show you, this is a patient. It's not going to work now. Bloody typical. Okay, let's go to the next one. So this is a patient who has, you can clearly see a macular lesion, and this patient had massive subretinal hemorrhage. Now, you can't really see what's happening underneath the hemorrhage because of the shadow, but this patient has wet macular degeneration, and the hemorrhage is intraretinal and subretinal and sub-RP. So I've got the 3 layers that I mentioned. There's no vitreous hemorrhage because you can't see anything here. So this was an example of somebody with wet macular degeneration. Next one is, oh, do you remember the patient that I said had constipation and had issues with the hemorrhage in the center? That's his, so this is Valsalva retinopathy. And what you can see here is that hemorrhage here, but what you can clearly see is that just before that, you could see the retina was okay, and you've just literally got the hemorrhage there between the vitreous and the retina. So laser treatment at the bottom edge of that would allow drainage of that hemorrhage. You can see it very clearly here. You can see that delineation of this hemorrhage sandwich between retina and the back of vitreous. And because they are young, the vitreous is gel-like, so it's not going to just bleed into it. But if you laser that hyaloid face, then it will bleed into it and they can see again. That effect can be quite dramatic. This patient has diabetic retinopathy, okay? And what you can see here, it's quite advanced. This is the macula obviously here, and over here, the retina is off. So this is tractional retinal detachment in patient with advanced diabetic retinopathy. So this retinal detachment, as you can see, RP separated from the neurosensory retina. And with these kind of patients, what we normally do is observe and make sure that that detachment doesn't come near the fovea. And if it does, then you need to treat. This is a patient where, before you have a look, I wanted to show you this unusual, do you see that there? This is another patient with diabetic retinopathy. So these are new vessels, and new vessels are coming from the venous system, not arterial. So these are venous new vessels, and they're always dangerous if they project into the vitreous. If you've got flat new vessels, often they don't bleed because there's no traction of the vitreous. But when new vessels project from the veins into the vitreous, and patient moves their eye, or you get a vitreous detachment, suddenly you get a massive vitreous hemorrhage. But actually, in this picture, we've managed to catch them projecting into the vitreous. So those are just abnormal tuft of blood vessels that you can see there, another one there, and there's a bit of macular edema there. You know, we can, as I said, we can do this in more detail when, if you guys are interested in a retinal course, OCT course, sorry. This is a patient with a branch retinal arterial occlusion. Remember I said when it's acute, you get the edema initially. And you can see here, compared to this side of the retina, you can see this part of the retina is quite oedematous. So that's what you get in an arterial occlusion. So you can just see a kind of edema in the retina. And I will probably stop after this. Let me just see if I've got one with a patient who has got, yeah, okay, good. So this patient has had a branch retinal arterial occlusion, some time has gone, so edema is gone, and then you get atrophy. You know that because when you look at this OCT, you can see that inferiorly, there is significant thinning of the retina compared to superiorly. Just look at the retina size when it starts coming down. Just goes flat. Okay, can you see that? So here, the retina is really thin. And when you see a picture like that, you know they've had a previous vascular occlusion. If I can just show you the very first one that it didn't show, that was just the wet macular degeneration. You can just see. Okay, here. All right, so stop there. You see that? That's the hyperreflective material of the abnormal blood vessels that are sitting just above the retinal pigment epithelium, and then you can see a bit of intraretinal fluid. But, you know, as I said, sorry, it's just a bit rushed with all this. I would need to go through OCTs if you guys are interested in that. And on that note, Pravi, do you want to come in with some Q&A?
Hello.
Hi.
If you could stop sharing your screen for me, please, Shah.
Stop sharing it. Okay, there you go.
Thank you so much. Thanks very much for that great
Sorry,
lecture.
quite quick, but anyway.
No, it was fantastic, and we've had a lot of positive feedback, so thank you. We do have quite a few questions. I'm going to try and get through if we can. The first one is, and I think you mentioned this briefly, but if a patient comes in and is found to have a recent PVD that we have examined, do we still need to refer them to rule out any tears that we can't see?
No, I think it just depends on how confident you are with examination. So things I'd be worried about would be pigments. So if there's any pigmentation, if there's any hemorrhages at all, then you should refer if you can't see a tear. If it looks like an obvious PVD, one thing I would say is you need to do a triple mirror to look at the anterior retina. So I wouldn't diagnose a PVD just with a 90D and that's it. You need to just learn how to do the gonio to look at the anterior retina. If that's okay and you're confident, which a lot of opticians are, that should be sufficient.
And if we don't have that mirror, Shah, what do you think we should?
Yeah, I would refer them because you need to do a full retinal exam. So I think, again, you know, COVID, if you've got no pigment, it's just PVD, you've done a look, looks generally okay, that's probably fine. They can call you back if there's a problem. But under normal circumstances, we would want to look at the anterior retina through a triple mirror or indirect ophthalmoscopy.
Okay, the next question is, How important is assessing dark adaptation when recognizing macular problems?
Yeah, so I mean, that's obviously important if the patient is, I mean, most of the times with wet AMD, the patient will come in with sudden onset central scotoma. They do tell me, especially the ones who have treatment, so they've had anti-VEGF therapy, they do kind of say, oh, when I go from light to dark or dark to light, that does cause me problems. So it's an important symptom, but I can't recall many patients who would come to me as a presenting symptom with wet AMD. So often it's sudden onset, distortion, and loss of central vision. Those are the main symptoms, but absolutely, dark adaptation is one of them as well.
Speaking of AMD, someone wants to know what's new in wet AMD.
So, as you know, most of you know about the Avastin, Eylea, and Lucentis that we currently use. So I think in a few months' time, there will be a 3-monthly injection, or it's marketed as 3-monthly injection called Beovu. And that just allows us to inject patients every 3 months. The first year data show that 50% of your patients can have injections every 3 months, which will be a great help for us because at the moment they're coming a lot more frequently than that. You know, obviously the stem cell stuff is going on in the background. It'll be sometime before that becomes available to most patients. But longer acting anti-VEGF Beovu should be this year, depending obviously when NICE approves it. But the only delay is because of COVID. So hopefully soon.
Thank you. Shah, can you explain what an occult membrane is, please?
Yes, sorry. So in the olden days, when we used to do photodynamic therapy or laser therapy for wet AMD, it was important to classify the macular, the membrane, the kind of choroidal tuft that was coming through as classic or occult. And that's to do with, it's a purely angiographic description. So in classic, when you inject the angiogram, when you inject the fluorescein, you can see the choroidal vascular network very quickly on fluorescein, and it's sitting on top of the retina. In occult, you can't really see it. So you can see a bit of hyperfluorescence here and there. It's not quite clear where that is. And it doesn't really matter now because you treat everybody with anti-VEGF, whether they're classic or occult. But with PDT, only classics were responding very well because you could target the laser onto them. And that's actually become important again because people are talking about radiotherapy, which is a new treatment. And with radiotherapy, it's important to know if it's classic or occult. So it's a purely angiographic description. In classic, you can see the blood vessels very clearly early on the angiogram. In occult, it's a very non-specific increase in kind of hyperfluorescence in angiography. That's all. It's just purely angiographic definition.
Thank you. There's a couple of questions on referral criteria for your wet AMD, and I don't know if the current COVID situation does affect this. So on that line, when we see a patient with wet AMD, usual protocol is via a specific local pathway.
Yeah.
In this current climate, I assume we do the same, but also if you're a locum and you're not sure what the current pathway is, do we send them direct to the hospital, or what's the...
Well, so first of all, I would say you almost ignore what NICE guidance says. If you're suspecting somebody with wet AMD, irrespective of vision, you must refer. I know at the moment they've got this 612 to 696 vision criteria for treatment of wet AMD. But if you see a patient, irrespective of what that vision, if the vision is better, you still refer them on. Now, every hospital, every optometrist or unit must have a pathway. So you essentially find out where your local NHS hospital is, if you're making an NHS referral. You can download the referral forms from the Royal College of Ophthalmology website for wet AMD. They're very easily downloadable. And you fill them out and fax it into their urgent referral. It's very important. So when we say fax, email it, sorry. So now where I work, the email comes through, it gets passed to the consultant and the consultant organizes it. I wouldn't send them to A&E with that. It needs to go directly to the urgent mailbox of the local trust for an NHS referral.
Okay. For a macroaneurysm, you said not an urgent referral. So if it's seen in community, should it be a routine referral? But now, given that it could take months, where does routine lie?
Yeah, I mean, I think if you're comfortable seeing it, so if you see a macroaneurysm, we would only treat a macro if the hemorrhage is kind of going towards the macula. So if the fovea or the, the central part of the macula is not involved, one could just watch it. I wouldn't treat that straight off. So you need to demonstrate progression. If the macula is involved, then that does need referral, because you might want to laser the macro to again, the time scale for that is not super urgent. So I would make a referral either way. I wouldn't sit on it, make a referral either way, but it's important to mention whether the macula, whether the fovea is involved or not. If the fovea is not involved, often we have a look again in a few weeks to see if it's getting better on its own or not. If it's not, or if things are getting worse, you might want to then do laser, which carries its own risk, but it's not as urgent as a patient with wet AMD or acute central retinal vein occlusion.
So if we are referring that on, but we're also watching in the meantime until they're seen, how often would we call them back to have a look?
You'd want to see them again maybe in 2-3 weeks time, just to see. Well, first of all, always tell your patients, if you're monitoring them, come let me know if you get worse. You've covered your back in case symptoms get worse. And I'd say if you want to check that kind of progression, 2-3 weeks, have a look again and see. Take a picture if you have one in your practice. That'd be really useful. Do an OCT scan. So if there is no progression, then you can carry on watching that situation. We would only treat a macro if the fovea is involved, or if you're worried that they might get a vitreous hemorrhage.
Okay. We have quite a few questions actually, Shah. I'll keep going with a few more of them if that's okay.
Yeah, I'm happy.
Let's do detachments. One, how do we know in practice if the macula is on or off? I assume if we don't have an OCT. And also, are there any tips you can give us on how we exclude a retinal detachment during examination? How do we know we've viewed far enough?
Okay, yeah. I mean, I think, to be honest, if the retina is detached enough to give them symptoms, you won't miss it. So just make sure that you're looking at, you've asked the patient to look up, down, in all extremes of gaze to see you've gone far enough. Obviously, use a lens that is like a super field so you can see as far as possible. Macular involvement is central vision. So if they've got good central vision, so when you do your vision test, then the macula is not involved. But I think MAC on retinal detachment is an urgent referral, so you need to refer straight away. I know a lot of people worry about missing a tear. So things that, look, you've got to look for are, can you see pigment in the eye? Can you see hemorrhage in the eye? If you can see either of those things, you really need to look for a retinal tear. And I don't think anyone will be annoyed, or they shouldn't be, if you can see that and you can't see a tear and you want somebody else to exclude it. I would learn the skill of using a triple mirror, because it is quite important to look at the anterior retina. And if you can do a gonioscopy, then learning triple mirror is no different. You just apply the mirror and just have a look around. Some people have other ways of doing it, but as I said, it'd be a good skill to learn. But with retinal detachment, if the retina detachment is causing symptoms and they've come to you, then you won't miss it. You won't see a tiny bit. It just tends to be quite big or significant.
Okay, I will take one more final question, is one on uveitis.
Yeah.
Someone's asking, surely even though it's COVID-19 at the moment, it should be an urgent referral if we see uveitis if we can't treat?
Absolutely, you should. Yes, absolutely. So I think I would always see a uveitis patient, and for the reasons I mentioned. I think if you're seeing a uveitis patient for the first time, certainly if they've not been diagnosed before, you must look at the back of the eye, because posterior segment involvement is quite important. And yes, absolutely, I would refer that on because they can have high pressure and it can very quickly go out of control. Actually, whilst we're on this, I see maybe something like 6 or 7 wet AMDs a week in Eastbourne, and we have got an old population here. I've not seen any in the last 3 weeks. So a lot of people are not coming on. I had another patient who called with pain, photophobia. We said coming, they were worried about COVID. A week later, they're on with counting fingers vision, florid anterior segment uveitis, high pressure. So actually a lot of patients are staying away, and I think I understand why. But if you have got an emergency problem, they must turn up. Otherwise, it can, it can affect them. And we're going to see a whole effect of this once this crisis is over.
Perfect. And we've had a few responses towards your last slide. We've got some very brainy optoms on this.
Okay, let's see who gets the bottle.
While you discuss this, though, I am going to launch a poll, if that's okay, Shah.
Yeah, that's fine, yeah.
So if everyone could just fill out this poll while Shah talks about the final slide. If you're on your phone, you will need to click the launch poll button. So it just gives people a chance to do this. So, but Shah, when you're ready, you can...
You want to share the screen?
No, you're fine. So we've got some people saying...
okay. What have they got?
We've got commercial retini.
Okay, that's a good answer. It's
retinopathy.
Oh no, who said that? How many people have said? Sorry?
We got a few. We had a few of those. So
yeah, Persia's retinopathy is right. Oh dear, I might be out of pocket at the end of this.
You've got two, so exactly.
Okay, fine. Well done. It's Persia's retinopathy. Yeah, so you can get that. Actually, I did fib. The patient had pancreatitis. So you can get Persia's retinopathy with significant chest trauma and pancreatitis. But I thought I'll throw them off a bit if I said if they're in a car crash. But yeah, Persia's retinopathy. Well done. So those are just, they look like really large, huge cotton wool spotty type lesions. Because you've got interruption of blood flow to retinal nerve fiber layers, and she, in her case, actually, she settled down in time, and the lesions just recovered.
So what do you do? So in terms of treatment, just wait.
Yeah, I mean, you treat the underlying problem, and things get better. So
great, thank you.
Well, when that was first put up, I didn't get it, so maybe they should.
I didn't get it either.
And also, if they're interested in the OCT talk, as I said, I've got a whole load of OCTs discussing vitreous disorders and inner retina, mid and outer retina disorders. So, but that will take an hour on its own. So if that's something that you guys want, please let you and Veronica know, and I can do that.
Shah, thank you so much. It's been a fantastic talk. Thank you everyone for coming in and tuning into this webinar. As I said, we do have another webinar tomorrow, and that will be given by Susan Sarangapani, who is another consultant with us. Her lecture is on dry eye, does it matter? Advances in the diagnosis of dry eye disease. So please find the registration link on our Instagram page or our Facebook page. Otherwise, you can email me if you'd like me to send you the registration link so you can log into that. And thank you all for joining, and have a lovely afternoon and good weekend. We'll see you tomorrow before then, but thanks very much. And Shah, thank you very much for that.
Thanks guys, take care and stay safe. Thank you, bye.